So we'll be starting with MRCS OSCE examination stations. So since I have to revise for my MRCS OSCE station, so what I am trying to do, I'm trying to study the Sala notes at the MRCS notes with you guys online. Okay, so it will be fun. We'll do rapid revision of the all the examination stations and history, taking everything one by one. So first we are starting with physical examination. So for every examination, the essential steps are this wipe. Okay, so as you can see, wash hands, introduce yourself, confirm patient's name, then we have to explain the procedure and ensure privacy. We have to ask for the chaperone if necessary, and also we have to take the permissions, consent, also relevant exposure of the examining limbs or whichever area you have to examine. After the examination, it is very essential that we have to reposition that exposed area. So, and lastly, we have to ask for the painkillers or any sort of discomfort before starting the examination. See, the OSCE stations or the examination is not just about the knowledge. The skill part is very much necessary, or I would say it is more crucial than the knowledge part. Knowledge part is something that most of us has an average idea. Some will score a little bit higher marks, some will score less, but the critical skill station is something that's the key factor in deciding the pass or fail. Okay, so now we'll be starting with knee examination. Okay, so here we'll get the two type of scenarios. One can be the osteoarthritis case. So it will be a case of chronic knee pain, and the probable findings can be the crepitus, which can be felt with both active and passive movements of the knee joint. Okay, or decreased range of motion. Then we can have the sports injury case, like a young patient with a football injury or with any contact injury, and then most likely the case we get in the OSCE station is of meniscus injury along with the MCL or LCL injury, or it can be an ACL PCL injury. Okay, so on examination the particular finding would be an antalgic gait along with tenderness over the lateral, or it can be over the medial joint line if it is a medial meniscus injury. Then in findings, very important finding, we have to see for the locked knee inflection. So patient will not be able to extend the knee. There will be positive varus test, positive McMurray's test. So positive varus test denotes the lateral collateral ligament injury. Positive McMurray's test with externally rotated ankle denotes the medial meniscus injury, and if we are doing the McMurray test by internally rotating the foot, then it is showing towards the lateral meniscus injury. Okay, so now for every examination, like, we have to ask the permission of the patient, the consent part, and we have to explain. So I'm going to examine, I'm going to have a look around your knee. Is that okay for you? Do you have any sort of pain? Do you want any painkillers? Okay, so these should be the standard lines that we have to practice, and I'm free to welcome any sort of feedback or any sort of better comment that would be beneficial in the examination. Okay, so you can suggest me. Now in the examination, in the inspection part, so we'll check for the alignment, we'll check for the flexion and hyperextension. From the side, we'll check for the deformities, scars, swelling, prepatellar, infrapatellar swelling, muscle wasting, okay, erythema, asymmetry, Baker's cyst in popliteal fossa. So for that we have to make the patient prone to check for the popliteal fossa. Then along with that we have to check if the patient is using any crutches or walking stick. Then gait, very essential, very important. Now, after the inspection part, I am going to tell the patient that, okay, now I'm going to feel around your knee. If you feel any sort of discomfort, kindly do let me know. So temperature, tenderness are the first two important point for any palpation test. So check for the temperature, compare it on both the limbs, then tenderness. We have to ask the patient if there are any sort of localized pain. Then quadriceps circumference we have to measure 10 centimeter above patella. It should be at the same landmark on both the knee. Effusion, so this is important. How to check effusion? Cross fluctuation, patellar tap test, for large or moderate effusions, milking test. Okay. Now the palpation, palpate the for with the knee flexed and 90 degree. Okay. So we have to palpate the bony landmarks. For patella, palpate the borders for tenderness, effusion, tibial tuberosity is important, head of fibula is important, tibial and femoral joint lines, medial lateral joint lines are important, collateral ligaments, both medial and lateral, and popliteal fossa is important for Baker cyst. Now movements. So we have to check for the both active and passive range of movement, flexion and extension, that is very important in the meniscus injuries. Muscle testing, we have to check for the quadriceps, hamstrings, muscle. Now special tests, so these are important. Posterior sac sign, it is important for PCL. So like in the image we can see during flexion of the hip and knee and aligning the knee as shown in the image, and we have to support the limb with our arm, and then we have to tell the patient to be in a relaxed position, and if there is a sagging of the tibia, that is showing that posterior support is gone, that is PCL injury. Okay. Now anterior and posterior draw test. So with the patient in supine position, and the knee should be flexed 90 degrees, and the feet are stabilized in a neutral position, and we have to sit at the forefeet of the patient, grasp the knee with both hands, and then with the tip of your thumbs should be just below the joint line, then pull the tibia forward. The amount of anterior translation of tibial and quality of endpoint can be assessed. Now Latchman test, like we can see in the image. In the 30 degree of flexion, again the patient would be in a supine position, then we have to grasp the thigh with one hand, and with other hand you have to grasp the tibia at the level of tibial tubercle. Okay, so the hand on the thigh should have stabilized it, and the hand holding the tibia pulls it forward. Amount of anterior translation again would be compared and measured. So varus and valgus test for MCL injury, varus test for LCL injury. Again in the supine relaxed position, the examiner holds the leg in his axilla with the knee in 20 degree of flexion. With both hands the tibia is held firmly in such a way that the thumbs are on either side of the patellar tendon. Okay, so it is important, thumb should be on either side of the patellar tendon, and the index fingers are placed on the femoral attachments of the medial and lateral femoral condyles. So index fingers on the femoral attachments. Then valgus stress for the MCL and the varus stress for the LCL is applied, and the amount of opening is noted. Now MRCS test. So how it is done? Again we have to see the image. For MRCS test, again patient in a supine position with knee flexed and relaxed. One hand supports the knee in such a way that the thumb and index fingers are on the medial and lateral joint lines. Okay, thumb and index fingers are on the medial and lateral joint lines. The other hand grasps the foot. So to test the medial meniscus, like I said earlier also, To test for the medial meniscus, we have to externally rotate the foot, and then with varus stress to the knee joint to close the medial compartment, and then the knee is passively extended. To test the lateral meniscus, for the lateral meniscus, internal rotation force is applied to the foot with valgus stress to the knee joint in order to close the lateral compartment and the knee is passively extended. Okay. In theory, it seems like a complicated test, but it is an easy test, as you will practice on your friend or whichever way you have to practice it, so that it will be easy for us to demonstrate during the examination. Okay. Now we'll discuss. Now we'll discuss about this case in short. So the male patient who had a non-contact sporting injury where he twisted his knee, on examination he has an antalgic gait. His range of passive movements was not affected, but active movements are limited by pain. Now he did not have any localized joint tenderness. Varus stress test and MRCS test was positive, fitting with lateral collateral ligament and meniscus tears. Okay. So now, how we have to present this in the exam settings. So I have examined this patient, whatever the name is. So we'll take, for example, Robert, 32-year male. So I have examined Mr. Robert, 32-year male, presented with sports injury on his left knee. On inspection, on his left knee, on inspection, there was no visible swellings, visible scar. There are no visible scars, muscles wasting, nor asymmetry. The patient had an antalgic gait or a limping gait, whatever you feel comfortable. Both of them are correct. On palpation, the temperature was equal on both sides. There was some tenderness over the lateral aspect of the left knee. No discrepancy regarding quadriceps circumference in both limbs. The patient didn't have knee effusions. It is important to comment on the knee infusion. Now on testing for the movements, both active and passive movement, I have checked both active and passive movement of the left knee joint. The patient has decreased range of motion, especially on extension, with no palpable crepitus. Now patient had a positive varus stress test, which may indicate the presence of LCL injury, and positive McMurray test, which may indicate the presence of lateral meniscus injury as well. Now the questions, very important one. What are the DDs? So apart from if our primary diagnosis is LCL injury and lateral meniscus injury, so it can be MCL injury as well, or it can be an ACL PCL cruciate injuries, or it can be a combination injuries, ACL injury with medial meniscus or lateral meniscus, or it can be a bony injury. Now what investigations would you perform? Initially I would like to have a weight bearing x-ray of the knee. However, the most important investigation would be a knee MRI. Very important. What to look for in MRI? So increased internal signal intensity in the meniscus. That is very important. And abnormal meniscus shape. For example, if we want to look for, we have to comment on the MCL LCL injury. So again, we have to check for the altered signal intensity in the MCL LCL. Also, we have to check for the continuity of MCL LCL. Now management, either conservative or operative. Always tell management, drug management, anything in a systematic way. So conservatively, we can have a rest along with the necessary braces, knee immobilizer. Then we have to do ice fomentation, compression bandaging, and elevation of the affected limb to minimize the swelling. Operative management can be repair of the meniscus or partial meniscectomy. Similarly, for MCL LCL injury, it can be conservative operative management, in which we have to repair the collateral ligaments. Now, X-ray features of the osteoarthritis. What are the X-ray feature of osteoarthritis? Very important. So before discussing it, I want to discuss this thing that on the OSCE examination, these are the particular questions that the examiner is going to ask. It is not like if he is starting to ask the X-ray features of the osteoarthritis, he will likely to go deep into this topic. Nothing sort of that. They have particular fixed questions and they expect particular this fixed answer. So we have to mug up this, and that's the key to succeed in this examination. Now the X-ray feature of osteoarthritis, four main essential features. First would be the narrowing of joint space, second subchondral sclerosis, then cyst formation, and then osteophyte formation. Okay, narrowing, subchondral sclerosis, cyst formation, osteophyte formations. How is osteoarthritis of the knee managed? Again, like we discussed, conservative or surgical. So conservative management is to first maintain a healthy body weight. Either it has to be we have to aim for decreasing the weight, so that will decrease the force going through the affected knee joint. Then secondly, very important to do regular knee strengthening exercises that will keep the muscle strength around the knee joint. Okay, for example, cycling is beneficial. Now we have to take care of pain, so analgesia is very important. NSAIDs particularly we have to avoid in patients having gastric irritation, chronic gastritis history, so we have to switch the drugs accordingly. Then heat application is essential in maintaining the joint relief, joint pain relief and stiffness. And physiotherapy or intra-articular steroid injections can be also given. Now surgical option, either it can be arthroscopy and arthrocentesis, or it can be realignment osteotomy like proximal fibular osteotomy, PFO, or it can be high tibial osteotomy. So these are temporary procedures that provide a patient a duration to postpone the osteoarthritis, and the main curative procedure is total or partial knee replacement. Okay, so to summarize, so patient position should be standing to inspect for the gait, and then we have to inspect the patient lying on the bed in the supine position, prone position, exposure hip to ankle. We have already discussed about, first we have to look, in that we have to check for the gait, skin, no scars, erythema, muscles, no muscle wasting, swelling, no swelling, effusion is important, Bursi or Baker's, asymmetry, deformity. Then we have to look for, on palpation we have to feel temperature, tenderness. In this case, this is a case of LCL and meniscus injury, so there is a tenderness over the lateral aspect of the knee joint. Effusion, we can do patellar tap test. Quadriceps circumference equal here, these are usually affected in chronic cases, so equal quadriceps circumference bilaterally. Range of motion, no limitation of movement. If there's a meniscus, medial meniscus injury, mostly there is a locking of joint. Inflection, hyperextension, no hyperextension. Now for cruciate collateral meniscus, we have already discussed the test. For cruciate, it is anterior posterior rod test, we have to check. So here it is intact. Collateral ligaments here also intact bilaterally. If there is a LCL injury, we have to comment positive varus stress test. And for meniscus injury, we have to comment positive McMurray test. Okay.